At the time, the approach that our system was committed to across the system as a quality improvement approach or methodology was focused PDCA, and probably all of you are familiar with this quality improvement methodology. So this was something that we did educate all of our committees about how to utilize it, and also to ensure that they were interfacing with the quality improvement folks within their own institution to be, if not on the committee, at least in relationship with the committee. Now, since then, there's been question whether we should use Six Sigma, which is another quality improvement methodology. We've chosen at this point not to do that. We have financial thresholds within the organization when to use Six Sigma because of the intensity of the labor around the Six Sigma approach, as well as we have financial benchmarks for when Six Sigma would be implemented, and these kinds of cases would typically fall below that financial benchmark. So we rolled this out 5 years ago. And what did we experience within the first couple of years? We knew that it would take at least a couple years for people to make the transition. It's taken some more than a couple years to make the transition. The surprising situation for me was that I expect the committees that were outstanding with the traditional model would make an easy transition to this model because they typically had strong leadership, good resources, well-versed in the principles of ethics, etc. They were resistant. I mean, they all made a verbal commitment, yes, they would transition, but huge resistance. And looking back, the resistance was they were so happy and content, they didn't see enough value in the new model. We didn't create enough of a burning platform for them to transition to the new model. So even though they gave verbal support to transitioning, they really didn't want to transition. So that was one group that we had initial difficulty with. The other were committees lacking resources, whether they were in knowledge, expertise, leadership, dollars, etc. The third obstacle were organizations that didn't have strong improvement, quality improvement folks, or it wasn't well integrated within the organization. Those organizations also had difficulty making the shift because this model is dependent upon quality improvement methodology, and if it wasn't well known or there wasn't a strong leader for that within the organization, it didn't advance the work of the committee. So we had to address all of those. So I give those to you as sort of warnings if you at some point want to make this transition to next generation. These are some of our learnings that may be cautions for you. After 5 years of working with the model, sort of this is where we are. We still have conceptual agreement about the value of the model across the system. We've had some implementation challenges, and most of those, the more serious obstacles, I think are behind us, although we still have some of our committees not as well advanced as others for various reasons, usually specific to the culture of the committee or the organization. But we have, after 5 years, some successes and best practices, and I'm going to share a couple of those with you this morning. Another key implementation challenge that we had is when we asked ethics committees to identify opportunities for process, structure, system improvement. There was some confusion initially on how to do that, the sort of the practical aspects of how do we identify what's at issue, or of many issues, what's the most significant issue. Some of that had to do with the fact that they weren't well aligned with quality improvement departments and those people doing it within the organization. When they got better aligned, I think they were better at identifying those, and ethics committees either as a committee itself can identify ethics improvement opportunities, and we ask them to identify them based upon what are the case consultations that they've had recently. So if you have a number of repeated ethics case consultations, say on futility or fetal treatment, what are the opportunities in that for improvement, for system structure policy improvement? Another interesting piece to this was when they identified an issue, whether they identified it as a committee or whether quality improvement was already involved in an improvement opportunity, but there was an ethics component to that project which quality had not recognized. So if you go this route, it's a great way to review one example of a project that's been in place for a while and two that have been initiated just within the past year and why we went the direction we went. I'm not going to run through this for the sake of time, but we're all familiar with fetal treatment cases, and this is just a representational fetal treatment case which goes from day 1 to day 24 with one disaster after another and different clinicians sort of representing different perspectives and not necessarily on the same page. And finally, it goes to the ethics committee. And the ethics committee, after 25 days, can't get the family to come to agreement with what where clinicians want them. And the physicians say they're wimps. They just don't stand up to this difficult family after 25 days. We've all been there, and that's sort of the typical fetal treatment case. What came out of these sorts of cases is the example that I want to share from one of our ministry organizations, St. Mary's in Grand Rapids, and Dr. Bill Passanolt's in the room here and is one of the key players in this transition. What was St. Mary's experience before they started this transition? I think it would be similar to the experience that many of you have. Not always a satisfactory resolution of conflict by an integrated and capable critical care staff, including social services and pastoral care. No matter what, we just don't have a satisfactory resolution. Late ethics case consultation at 3 or 4 weeks into the clinical course where opposing positions are cast in stone. How many times do we get called in, ethics committee case consultation teams, well into a case that folks had no idea was going on within their own facility? That always puzzled me how that happened. And so our approach is trying to make sure that doesn't happen. Unresolved conflict and a family that leaves the hospital with less than a positive view of their care experience. Our system as a whole is so committed to that last one not being a reality. We have a target within the system of with reference to the Press-Ganey scores on would recommend, which is the patient satisfaction score, which sort of shows the highest level of satisfaction that they would recommend the organization to their family and friends. We have a target of 90% for 2009 and 99% for 2010 on would recommend. So we can't be doing poor ethics case consultation and get a score of 99%. So what led to St. Mary's in Grand Rapids undertaking what they call the anticipatory integrative ICU care model? What was going on at the time was in the ethics committee, they were asked to review the fetal treatment policy. And it was the medical directors of the ICU, palliative care, and ethics that were looking at the futility policy. And basically what they realized was that no matter how they rewrote the policy, it probably was not going to be a very successful policy. probably all of us have some reflections on that. At the same time, what was going on within their culture was that they had a frustrated ICU care team because of these kinds of cases and dissatisfaction with families. They also were just at the beginning of initiating a palliative care program with a new palliative care physician. And at the same time, the organization was just transitioning to the next generation model, where we were asking them to look at systems and structures and policies for their ethical components. And so by the three of these coming together were sort of a synergistic moment for them to look at this with new eyes and in a different way. So they decided to develop this new model, and the priorities of the integrated model were that the committee would be proactive and integrative, patient-focused, ensure continuity of care, have outcomes that they tracked, and it was implied but not stated that it would be consistent with the mission and the core values. The way that they actually went about this are the goals of the model are these, and I'll get into the way they went about it. To identify and address the numerous conflicts that are never referred to ethics case consultation. So as they're looking at the ICU patient, could they identify and address in a proactive way conflicts that had not been addressed previously? Identify them proactively rather than having them surface through the clinicians and then have to react rather than be proactive. Enhance understanding of patient goals and improve communication among care staff and the patient and family. Turn the usually late ethics referral to an earlier resolution by the care staff, or at a minimum an earlier ethics intervention while physicians are still malleable. So try to move beyond when they were getting them at 3 or 4 weeks and people's thoughts were cast in stone. Physicians, move it earlier. How can we identify these issues as early as possible? How do we get to that data? And fix system inadequacies when recognized. Pay attention to the policies, processes, and structures, the system inadequacies, and fix those so that we don't keep redoing this over and over again. To achieve these goals, what they did was they expanded the team to include a much more multidisciplinary team, and you can see who's included in that. They meet weekly, Wednesdays, billed at 7 a.m. on Wednesdays, every Wednesday for the last 3 years, 7 a.m. to 8 a.m. I've had the good fortune of being at a couple of those meetings. And the folks come together with multidisciplinary perspectives, and they focus on each patient and identifying potential problems, their ethical implications, trying to understand where the patient is coming from, and intervene together in a coordinated manner. So try to be proactive in addressing this population so that you don't get sort of futile treatment cases or crisis situations down the line. Here are some of their outcomes. And I apologize because it got emailed to me the 2007 data, but I wasn't able to import it. So you can see average length of stay has significantly decreased since they initiated this approach. Hospital unit-to-unit transfers have also significantly gone down. Where it used to be you step down multiple times, now the unit-to-unit transfers have significantly decreased. The direct critical care discharge to hospice went from 0 in 2005. They're doing many direct discharges from ICU to hospice, which had not been the case previous to this initiative. What they've been significantly measuring and carefully measuring, because this always makes sort of the most sense to senior leadership teams when you're sort of justifying what you're doing, is the financial implications for the organization. And obviously, because you're shortening length of stay, the only way to measure that is through cost avoidance. So these are their calculations on cost avoidance. And ethics consultations in the critical care unit went from 20 a year before the model to roughly 7 and 6 in the last 3 years.